Racial disparities have defined the COVID pandemic since the virus was first detected in the U.S. in early 2020. But medical segregation and outright racism in healthcare delivery didn't begin there. Now, though, it's finally being talked about, but will words be met with action and funding? Joining me is Dr. Kedar Mate. He's president and CEO of the Boston-based Institute for Healthcare Improvement, which has focused on that issue, among others. Pleasure to have you.
Thanks
for being here. almost nonstop, and we're not alone, about racial inequities during COVID. But, you just go back a few years before this. I'll never forget that study that said white doctors thought the skin of black patients was thicker, that their nerve endings were less sensitive. And the sense I got of that, please correct me if I'm wrong, it was sort of dismissed by their fellow healthcare professionals, saying it's just them, they're outliers, no systemic problem here. Is that a fair statement?
I think that's a reasonable statement, yeah.
And you, from what I understand, you believe the cure for this, if I can call it sort of systemic racism denial, is data. Is that, what does that mean? Facts really matter?
Facts matter, data matters. Bringing data to the issue of inequities actually raises the visibility, raises the understanding of the fact that these inequities exist. I'll tell you a brief story. Whenever we work on this in our hospitals, we always get the initial reaction to any kind of data presented about inequity that's present in your environment. And the initial reaction is, this isn't my data, this isn't my information. But as you start to dig into it, you start to realize that these inequities are prevalent in our health systems all over the place. And in fact, they're happening every day in the work that we do in our clinical interactions with our patients. And if we don't actually start to look at that data and start to make improvements with it, we're going to be replicating the stories of the past.
I love the phrase you used in a stat story, stages of grief around data. That means it takes a while to settle in, kind of thing. One of the things I knew nothing about until I know you were coming here today, Doctor, was this. Blue Cross has put their money where their mouth is. $16.5 million channeled through you, which in turn go to 12 healthcare delivery entities.
That's right.
What's that money intended? We're going to put up a little graphic that shows some of the things we've read about what the money goes for, but tell me in your own words, what's it intended to do?
Well, we have a group of provider organizations, hospitals, health systems that are committing themselves to improving health equities and to reducing inequities that they see and discover in cancer care, hypertension management, stroke, diabetes, et cetera. But they need support from their payers, from the financial institutions that help to pay for this, the care that they provide. And what Blue Cross is saying is, this is an important priority for us. We want to reduce inequities in the care that we finance. And we're going to put our money essentially where our words are. And I'm really thrilled to be working together with Blue Cross Blue Shield of Massachusetts to try to make this program happen. They've supported us to help provide guidance and support to the providers themselves so that they can actually conduct equity improvement activities in their environments.
But if the providers engage in health equity improvement behavior, as you described a minute ago, within their four walls, that only does so much. I mean, what I've heard from everybody sitting in that chair on this issue for the last few years is, if you don't address the social determinants, does the kid, the patient, have nutritious food at home? Does he feel safe walking to school? Does she live in decent housing? That's the big ticket, almost impossible nut to crack, without which these other things never go from here to the goal line. Do they, or do they?
Well, it depends a little bit on the nature of the clinical problem we were talking about. So if somebody comes into your emergency department with a stroke, right, at that point in time, there's a potential situation that might arise where you could have a significant disparity in stroke outcome. We saw this with a partner organization we were working with in the Pacific Northwest. This health system, black patients, white patients arriving in the emergency room with the same signs and symptoms of stroke. The black patients had a delay in their care of over 20 minutes compared to white folks. And that causes a significant amount of loss of brain function that can lead to long-term disability and potentially early mortality.
And that can be fixed within the confines
can be fixed within the confines
facility.
of the healthcare facility. Now, if you're talking about asthma care or chronic diseases like hypertension, cardiovascular disease, some cancers, you're right. You need to actually work outside of the four walls of the health system to start partnering with upstream social care institutions to try to work on those social determinants of health. You can't accomplish better care for those kinds of conditions without engaging those a wider array of actors in the environment.
We talked in the beginning about doctors, poo-pooing it, sort of them, it's not us. People here have seen the reporting of my colleague Philip Martin about two doctors who confronted it head-on at Brigham and Women's.
Yes.
One of them came up with a study that showed if you're black and more likely to die from a heart problem, you're put on a general floor.
Yes.
If you're a white person and less likely to die. You're put on a cardiac floor with likely better outcomes. As you know, these neo-Nazis picketed them, death threats, those kinds of things. What does the healthcare community do to protect people like them so that there are other people like them?
Yeah, so that project, that work on congestive heart failure, happened in the context of IHI's Pursuing Equity initiative.
Oh,
So
really?
I know a lot about this, and Bram Wispelwey and Michelle Morse, the two
Those are
doctors
two
that you're
doctors,
talking
yeah.
about, they were part of that initiative that I'm describing, where we started to work initially with 8 health systems on improving health inequities in their care environments. The Brigham picked congestive heart failure as its topic to work on, found those inequities, documented them, and started taking action on them, and then you saw what happened with that consequence. Your question is, how do we ensure that doctors like Bram and Michelle continue to do that work? In fact, more doctors continue to do that work in this effort. And I think that's about finding community and actually elevating the importance of equity and improvement as part of what we do in healthcare.
Is there not a feeling that we should keep our heads down and we don't have to worry about those kinds of moments? Is there not a wave of that kind of thing?
When you look at the data and you see the fact that we have such prevalent inequities across our system, how do you avoid thinking about it? How do you avoid working on it? Here's the thing. Once clinicians are provided that data and they go through those stages of grief about the data aren't mine, the data are wrong, et cetera, once they get through that and they say these data are real, there's a need for improvement, clinicians are obligated by their oaths and their commitments to take action, and they do it invariably in the situations that I've had a chance to.
So those are healthcare workers doing extraordinary things. Let's talk about healthcare workers doing hugely important but ordinary things, just doing their job. We've all seen the numbers. We can put these up too. Doctors describing burnout conditions up more than 50% in a year from 20 to 21. Suicide rates up. What's being done on that front other than people leaving the profession?
This is a really important area of emphasis. There's so much going on right now about workforce safety, physical safety, not only just literal physical safety, like OSHA stuff, but also violence against physicians and nurses and other healthcare providers, as well as mental health and well-being of doctors, nurses, and all clinical providers. A ton of attention going into this. You're right, the data are very problematic. We have 93% of clinicians reporting some signs and symptoms of stress or burnout. We have significant numbers that are asking or suggesting that they want to leave the profession in the next year, 25%.
So what are you doing about it?
So right now we are working on a multi-part program, both on violence prevention and physical safety, as well as on ensuring mental health provision for healthcare workers, and working on helping healthcare workers to take care of one another.
Is there, it sounds odd asking this question of people who provide healthcare for a living. We know about the stigma. If you're in the military, you don't talk about, you talk about physical problems. You don't talk about mental health issues. We can talk about all the different industries. Same problem exists in the healthcare world?
Quite a bit of it. I mean, we have actually, there are stigmatizing questions that we get asked when we certify in our state licensing boards about whether we've ever seen a behavioral health provider. That question alone starts to raise the anxieties of our healthcare providers as to whether or not it's okay for me to see a behavioral health provider, which is a real problem right now.
And you think some don't because for fear of what the consequences may be for admitting
I think
it?
admitting that I need a behaviorist, admitting that I need to see a therapist is potentially a sign of a concern that might result in the loss of my license.
Are they right to be worried about it?
I don't know that a lot of that kind of threat has actually been realized, that we're seeing clinicians lose their licenses in these cases. But I think what's happening right now is we have to ensure that we have a lot more mental health services for our clinicians, that it's okay to ask for help. We have to normalize these opportunities for clinicians to seek services to enhance their well-being, and that's a part of what we're going to have to do going forward. I will say one last thing about this, which is that some part of the equity story connects to this issue around burnout, and it connects through the notion of moral distress. When you see a patient coming in and out of your emergency room with the same signs and symptoms, getting disparate and inequitable care, and when you don't have the power to actually solve for some of those social determinants that we talked about earlier, and you're sending a person out into the community with a treatment plan that you know they're never going to be able to follow, and they come back right into your ER next week with the same constellation of signs and symptoms, you do that over and over and over again, and you're going to eventually burn out. And it's not because doctors and nurses and other clinical providers aren't used to spending hours, tens, hundreds of hours sometimes, working really hard. But if you're working really hard and you're not making a lot of progress, that kind of thing is ultimately incredibly distressful.
I only have 45 seconds left. How worried are people like you about shortages, staff shortages? We know family docs, primary care physicians, a real problem. How big a problem is that?
Number one problem, any CEO I talk to in healthcare today, the number one problem is staffing of any kind. Nurses,
15
doctors,
seconds,
otherwise.
and what's the top of the list about what they're doing about it?
Starting to provide these kinds of services, mental health services, supporting their providers to do the jobs that they need to do, starting to create connectivity and connections into the community to solve the problems that these patients are experiencing, and that's the kind of thing that actually gives life and creates energy in the healthcare workforce.
Doctor, it's really good to see you. I hope you come
Pleasure.
back. Really
Thank you
appreciate
so much.
it. Thanks so much.
Appreciate being here.